Hi, good morning. We just did a in situ simulation in room 19, and this video is the feedback and summary of the debriefing points and observations that we discovered during that simulation. So the case was a person that was transferred from another hospital, and that person had a chest drain placed and a pelvic sling placed in the other hospital, which was appropriately done. And the person arrives, despite these interventions, to St. John Regional Hospital with an increasing shock state and increasing hypoxia and agitation. The first major feedback point, which sort of underlines, some of the core principles of transfer medicine, is that the laws of entropy and movement will seek to continuously displace any device or tube or line that you will be in the patient, and that your primary survey should be adjusted to include systematically reviewing the function of those devices. So what I mean by that is that when you do an airway assessment, normally you're looking to see if there's airway compromise. In the context of someone that arrives intubated, for example, you're still looking to see if there's airway compromise, but your frame is that you're looking to understand, has that tube been displaced either too far in or too far out based on the original depth of the lips? Is there signs of upper airway or tube obstruction based on the peak airway pressures? Is there signs of complete obstruction and emergency based on the end-tidal CO2 trace? Is there signs of heavy soiling? Does it need suctioning? You do an airway assessment, but your frame is looking, if they're intubated, to see if that tube is correctly situated. You would then be prudent to order a chest X-ray. I think that's probably standard of care for anyone that changes location who has tubes either in their airway or in their chest, and is done routinely in most intensive care units. From a breathing perspective, you're of course going to look for their respiratory adequacy and signs of either disease or injury. But in the context of a chest tube and or ventilation, is that strategy working? So from a chest tube, is it swinging? Is it draining? If it is draining, what is the output from the tube? If it is leaking air, what is the air leak rate? Is there signs of a massive air leak rate or massive bleeding? Or in the case of this scenario, which was deliberately constructed this way, the chest tube had actually stopped working, and the person was developing signs of a tension pneumothorax, so needs a chest tube reciting, essentially. So that's an important thing to identify. In terms of ventilation, if the person was ventilated, what are the peak and plateau airway pressures? What is the chest exam like? What is the chest ultrasound like? What is the chest X-ray like? What is oxygenation like? What is CO2 and end-tidal CO2 like? So I think you have to understand all those things to adequately understand the person's evolving disease or injury state, but also the adequacy of their ventilatory support. That is a minimum standard of assessment care in these patients. From a circulation perspective, you're going to want to know if there's wound packing or bandages or any type of splint. Have those things displaced or moved or stopped working? And in this scenario, the pelvic sling had sort of ridden up and was no longer over the iliac crest where it should be. It was more sort of like a cummerbund or belt around the abdomen, and it wasn't doing anything. I think that's very common if people are moving when their legs scissor. If the pelvic sling is here, when their legs move, it pushes the sling up, and that obviously is not adequate. So as was very immediately identified by the team in this case, the pelvic sling should be repositioned, and a pelvic X-ray should be performed afterwards, and should be compared to the pre-sling X-ray to ensure that there's either been adequate reduction of the pelvic fracture fragments, and to ensure there hasn't been increased distraction of the pelvic fracture fragments. So that's kind of the frame that I would use when receiving a patient. I do the same for disability. I would look at their Glasgow Coma Score, pupils posturing, movements, levels, and seizure activity, but I would also look to see their infusion rates of sedation analgesia, and was that adequate, or is there over sedation or over analgesia, which can obviously cause a lot of problems. And then from an E perspective, what is the temperature, what is the sugar, and then they need an immediate set of coagulation tests sent, because we're at that stage we should have moved on from empiric therapy, and we should be using measured blood transfusion practices, using good data from INR, thromboelastography, fibrinogen assays, and counts of platelets and CBC, and that should all really be something that is available at the bedside, not with a delay, just like a blood pressure in these patients. The next sort of big feedback point is around massive transfusion and the team economic cost of that strategy, which is usually necessary. So this person had received salty water, had received no blood, was critically hypotensive, and therefore had to have a balanced, until we have sort of clotting numbers back, needs a one-to-one-to-one strategy. If we do that, as well as it being a one-to-one-to-one strategy from a product selection perspective, it is a one-to-one strategy from a nurse use perspective. So if you are running an MTP, that is one nurse that is taken up completely for that process to be smooth and safe. And so we just have to consider that when allocating roles. The second observation from the MTP was that the level 1 transfuser, it's a 1980s piece of equipment that follows 1980s resuscitation paradigm, i.e. that's a 40-year-old paradigm that we're using in these patients, and that paradigm isn't, it has found not to be safe anymore, and that there are much better pieces of equipment out there. And we have ordered Belmont infusers. Jackie Fraser, our manager, tells us, and that there is a Belmont infuser en route to us, which is a far superior device, and that's good news. So they're the major feedback points. If you could please complete, if you attended, if you could please complete the review and appraisal of the simulation, which helps our program evolve. And if you have any other further comments or questions, please just send them in an email to myself. This email we sent around as a link, and there's a transcript on the Loom website. Loom is a fantastic device. I don't receive any sponsorship from it, but it's really good for recording these kinds of videos quickly as a note. It develops its own transcripts and chapters, etc. Right. So that is it. Thank you very much for your time, and great stuff. Thanks for getting involved. Thanks. Bye.